Tonight we're talking about some of the most recent science behind age and fertility, and as women, what we can do about it. So we're going to be talking about things like normal age-related changes in fertility, the difference between chronologic age and ovarian age, a powerful new test to detect fertility potential at any time, and ways to optimize fertility success in older women. And to get us going here, I'll just introduce Dr. John McNaught quickly. He is the medical director at Fertility Ontario here in London, Ontario. He's extremely passionate about his career and loves helping people build their families. He does a lot of outreach through social media and his website, and has greatly enjoyed this really successful webinar campaign that we've been doing over the past few months. So Dr. John McNaught, welcome to the call.
Thanks a lot, Melissa. You'll have to forgive me, I have a little bit of a cold tonight. Some of the information that we're going to go over tonight was originally aired on our first webinar back in July. And one of the reasons that we are revisiting that information tonight is because these webinars eventually find their ways onto our YouTube channel. And, you know, we have generally about 50 people who attend every webinar online, but there are several hundred more who visit the YouTube channel in order to get that information. The reason I mention that is to encourage everyone to be interactive, because this is really a collaboration where we're all trying to learn more from one another. And if you can think of some questions that are important to you, chances are that's going to be a question that someone else will want answered for them, and perhaps they're not available to attend live. So there will be lots of opportunities throughout the webinar. We really like to keep these as interactive as possible. So if something is important to you and you would like to talk to me in an interactive way, please don't hesitate. What we're talking about today is, I think, a very timely topic, particularly as we approach 2013. And that's because with each passing year, more and more women are delaying their fertility into their mid-30s, late 30s, early 40s, and even to their mid-40s. And a lot of people are not as informed as they could be as to what their family building options are as they get older. So before I get into the presentation proper, I just want to talk about our format. We're very much into personal confidentiality as part of our webinar program. So in the same way that we encourage you to be interactive, you do need to know that other attendees on the call can't see your information, can't see your text questions to Melissa, and don't have any means of identifying or contacting you. So, you know, feel free to be as open as possible, because you have total confidentiality in the system. Melissa is key to what we're doing here tonight, as I'm trying to go through my material and stay on task. She'll be moderating all of your questions through our text box, and she will interrupt me from time to time in order to give us an opportunity to engage interesting questions. And finally, we need you to know this information is very general. So we can't provide specific medical advice because I'm not in the same room as you. I can't identify you particularly, can't do a physical exam or take a history. So this is very general advice that would apply to women in general and not specifically to your medical situation. And that's just sort of a legalese that we need to start all webinars with. What we're going to be talking about tonight is basic biology. We always start with the basics because it's so important. We'll talk about changes with age, and some of the information is surprising to people because in general, North Americans tend to overestimate our fertility potential and underestimate the changes that happen with age. We're going to talk about an important concept, chronologic versus ovarian aging, and look at the difference that happens at the level of the ovary as opposed to what you might see on your driver's license. We're going to get in depth somewhat into AMH testing, or anti-Müllerian hormone testing, which has been an absolute game changer for fertility care in the last 2 to 3 years. And it is a remarkable, easy to acquire test that tells you a lot about your fertility potential. And lastly, we're going to talk about simple ways, things that you can start doing almost immediately that will enhance fertility success regardless of age. So the basics are that all women are conceived with a certain amount of eggs, and for some reason those eggs are depleted from the moment of conception. And even before a female child is born, a large amount of the eggs within both ovaries are depleted even before childbirth. And that's something that we don't have a great explanation for in medical science, other than we certainly understand that not every egg is destined to be a mature adult human being. Some of the eggs play a supportive role. Some of the eggs are really never mature enough to reach full potential. And ultimately, only about 400 eggs in an adult woman's lifetime will reach maturity as a result of ovulation. And you can think about that 400 ovulations over the result of the average female life only represents so many opportunities at viable pregnancy. This is a concept that I think a lot of us are aware of, women more than men, the concept of the biologic clock. And whether you're using birth control, having your own family, or undergoing fertility therapy, your biologic clock is always ticking. It's thought of as a pool of eggs, and this pool is constantly depleted at a relatively constant rate. There are things in life that can cause an insult to your ovarian reserve and deplete your reserve more quickly, but for most individuals, it's a slow and steady decline. The remaining pool is often referred to as a woman's ovarian reserve. As the ovary ages, and this is very important, new eggs are not produced. Patients will often ask me, how do I get more? How do I produce more? And the answer is always the same. It really and truly is not possible. So as that initial amount of eggs that you're given at conception is depleted, there is no means of replenishing that supply. And as you get to the bottom of the ovarian reserve, the quality of the individual egg is thought to diminish along with the quantity. This isn't true in all cases, but tends to be true in women who are older. Again, one of the most important concepts that I'd like you to walk away from this call with is the concept of ovarian aging. We all know that with each passing day, we get older. We like to ignore it sometimes, make jokes about it, sometimes even pretend like the process isn't happening. But I'm pretty sure that every day, every single one of us is a little bit older. The age on your driver's license, your chronologic age, is very different from ovarian aging, because not all women deplete their ovarian reserve at the same rate. And as we know, based on a calendar, we all age day to day on the same rate. The unfortunate thing in terms of fertility is that ovarian aging happens more quickly for some women as opposed to others. It's very important to understand some of the changes that happen as you get older, both with respect to becoming pregnant, staying pregnant, and having a healthy pregnancy. If you look at these statistics here, this information is unfortunately still taught in medical schools. And the reason that I put this picture of these two junior doctors up is because this is the very basic understanding of female fertility that unfortunately most doctors graduate medical school with. And it goes back to a very old population study done in a Hutterite community that examined the percentage of the occupants who were pregnant after a certain number of months. We see that the highest amount of pregnant patients occurs in the first 3 months of trying. Within 6 months, 72% will become pregnant, and after a year, about 85% will be pregnant. And this is statistical information, albeit from the 1950s, that the definition of infertility is actually derived from. Although I can't disagree with the results of this study, I feel the need to point out that it's no longer 1956, and most of the people on this online webinar right now are not members of a Hutterite community. The point of this is that these statistics aren't particularly salient to the modern population. We know now that with each passing year, women attempt pregnancy at an older age. So the proportion of North American women who attempt pregnancy beyond age 40 increases year after year after year. If we look at conception rates within 2 years and break it down by age, we get a much different story than what we're seeing from our population study from 1956. Young women, less than 35 years old, have a pregnancy rate per cycle or fecundity rate of about 20 to 25%. And if someone asks you, what is your chances of becoming pregnant in a given month, that's generally the answer, 20 to 25%. That's also the benchmark by which all fertility therapies are measured, because our job is generally to increase the odds of you becoming pregnant. And if a fertility therapy is effective, it generally has a pregnancy rate of more than 20% per cycle. However, those numbers don't hold true for everybody. We see that beyond age 35, the numbers decrease significantly, down to a 9% drop from patients who are younger than 35 years old. At 40 years and above, the monthly pregnancy rate is 8 to 10%, and more than 40 years, it's only 1 to 5% per cycle. And the longer a 40-year-old patient has attempted pregnancy, the less chance monthly that pregnancy will occur. I'm going to stop there briefly and just let people soak in those numbers a little bit. Are there any questions about that particular slide?
So far, John, we don't have any questions, but again, if you have any questions or you wonder really what these numbers mean, just type it in into the little question box that you have up on your GoToWebinar panel and we'll answer them for you.
again, and I'm happy to move back if it suits people. The important take-home point here is that it is absolutely true that women in their 40s can become pregnant. But statistically, the chance of that happening on a month-to-month basis is significantly decreased in comparison to women who are less than 35 years old. So if there is a magic number, it probably is 35. And with each year that you move beyond age 35, although not impossible, you can expect an uphill battle in terms of building a family.
Awesome. And John, we have a question here from Alicia. She says, so in 1 year, you should technically be able to get pregnant if less than 35, statistically speaking, right?
Statistically speaking, most women less than 35 have a high chance of pregnancy. If 12 months have gone by and someone less than 35 years old has not become pregnant, realistically you need to be seeking specialty help because your body is telling you that something is not right. Young women get pregnant, and if young women don't achieve pregnancy in a relatively short amount of time, that tells us that something's up. We don't want to be alarmist, but at the same time, we don't want to ignore obvious contributors to subfertility.
Great. Awesome. That's all the questions we have right now, John.
Great. So we know that getting pregnant alone is more difficult as you get older. Anytime that we have this conversation, we also need to discuss what happens after pregnancy occurs. And one of the heartbreaking truths of pregnancy in older women is that there's an increased risk of miscarriage. There's also an increased risk of genetic abnormalities, which is probably where the increased risk of miscarriage comes from. And unfortunately, there's a decreased success rate with fertility therapies. Once a patient has achieved pregnancy, there's often an increased need for cesarean section, an increased incidence of high blood pressure, incidence of gestational diabetes, and other surgical and medical obstetrical complications. So we advise most people who delay their fertility to go into the process with eyes wide open. Although the overall incidence of these complications is still relatively rare, you will always be compared to your younger cohort. And when an older patient is being compared to someone less than 35 or less than 30, there's always going to be an increase in the attributable risk.
And John, I've got a question here from Michelle. She's wondering why there's an increase in having a C-section as you become older.
Yeah, the thought with that is that the uterus is a muscle, and younger muscles tend to work more efficiently, and older women, not that they're unfit, but oftentimes their uterine muscle doesn't work as efficiently as someone who is younger. As well, we noted that the incidence of gestational diabetes increases as you become older. One of the complications of gestational diabetes are babies that are very large in relative to their peers, and they often get very large in the shoulder girdle. Babies who are exposed to either insulin resistance or gestational diabetes have an increased need for cesarean section just because they're too big for a successful vaginal birth.
I see. Wonderful. And Michelle says thanks, and that's all the questions for right now.
Okay, great. I just wanted to show this graphically a little bit. This is one of the handouts that is provided at our clinic, and it talks about the effects of assisted reproductive technology cycles relative to live birth and miscarriage. Now, not all couples who are attempting fertility at an older age will actually go through assisted reproductive technology. A lot of our patients strive for natural pregnancy, and that's something that we're known for at Fertility Ontario. But this graphic very closely mirrors what we see in natural fertility as well. And that's as the age increases, we see the live birth rate drop sharply right around age 35. Similarly, at age 35, there's a sharp increase in the rate of miscarriage. So we don't want to get too much into the concept of a magic number, but for most people, what I advise them is beyond age 35 and 36, you should be anticipating an increased challenge in terms of having a successful pregnancy. One common misconception that we try to deal with on a daily basis is the concept of a bailout. We have a lot of people who delay their fertility because they see examples in popular media, often celebrities, of people receiving a tremendous benefit from advanced fertility therapy. Many women think that they can delay their fertility well into their 40s, and modalities such as in vitro fertilization can overcome the decrease caused by a delay. And many patients lack awareness regarding the limitations of modern fertility therapy. As you get older, IVF becomes considerably more difficult. And there's actually a subset of patients who are going to be more successful using natural fertility as opposed to in vitro fertilization, because natural methods tend to keep the eggs inside the body, whereas in vitro fertilization, by definition, the eggs are taken outside of the body, which is a tremendous stress to them. And younger eggs tolerate that stress better than older eggs do. And again, looking back to our previous slide, we see that the live birth rate associated with fertility therapies drops sharply in conjunction with age. If we look at Canadian data and we look at IVF and ICSI cycles, which is the most advanced fertility therapy available, this is from our national registry from 2010. We see that most people who attempt advanced fertility therapy beyond age 40 do it in their first year. So 60% of those cycles were amongst patients aged 40 to 41. And even then, using our most advanced therapy, there was at most a 25% pregnancy rate. If an additional year passes, we see that pregnancy rate drop to 15%. One more year, age 44 to 45, and there's a generous estimate at 10% of live birth rate. Personally, I have never seen a live birth from in vitro fertilization in a patient age 43 or older. We have had some pregnancies, but inevitably they've miscarried. And beyond age 45, I absolutely refuse to do in vitro fertilization in a patient because I have no medical evidence that it's going to be of benefit to them. Now, that is not to say that you cannot become pregnant at these ages, but the message here is that there is a point at which even the most advanced allopathic medical therapy available can't increase the chances of you becoming pregnant. So technology is not a bailout. If you want to become pregnant, the best thing to do is prioritize family building at a younger age. Any questions popping up on this one?
No questions yet.
Okay. We're going to spend the next segment talking about testing of fertility potential by AMH levels. It's a very important concept and something I'd like to spend some time on. Before I do that, are there any questions regarding the previous segment on fertility therapy in older women?
We'll just wait a sec here, John. So far nothing yet, but again, if there's ever a question that just pops into your head, even if it relates to, you know, a few slides back, no worries, just type it in and we'll either address it on the spot or we'll save it for the end.
Sounds good. So what we're going to get into in our next segment is anti-Müllerian hormone testing, a blood test that's been offered in Ontario for the past couple of years, and something that is still in the realm of research. Most of us in the fertility industry now see this as a standard of care, meaning that it needs to be a first step in the evaluation of someone who's trying to build a family. Anti-Müllerian hormone is a relatively stable hormone that is made by healthy small follicles within the ovary. Follicles are the fluid-filled sacs that actually contain eggs, and before they become stimulated, they lay in what's called an antral state. And for a number of years, we evaluated fertility potential by counting the antral follicles by a delicate ultrasound. The issue with that was that you needed to be exceptional at ultrasound in order to accurately count the antral follicles. The AMH level is far more stable, doesn't require ultrasound equipment in order to detect it, and is more consistent than an antral follicle count. The nice thing about it, it is irrespective of age and differentiates nicely between biologic and chronologic ovarian aging. This is a sample report of what I go over with patients when their AMH levels come back from Toronto. Our current practice is to draw the blood right in our office, and then once a week it's couriered off to a specialty lab in Toronto. And that lab is actually where most of the AMH testing in the province is done. Because most of the results end up in that particular laboratory, we get consistent results. And you can see here that this is the sort of thing that we go over. We don't know how old this patient is, and neither does the person who performed the AMH test, because AMH is not reported relative to that patient's birth date. We see here that this patient has an AMH level of 19.1. which is expressed in picomoles per liter, which is a very small amount, but enough to differentiate between high, medium, low, and very low ovarian reserve. For my purposes, or at least what I'm looking for when I'm evaluating somebody, is a value of about 15 or so. For most patients, an AMH level of 15 suggests very good ovarian reserve, something that we can work with and assure an excellent opportunity at pregnancy. When the value gets below 15, we know that there is going to be a guarded prognosis with respect to fertility potential. This test relates most strongly to prognosis in vitro fertilization and more advanced techniques. It doesn't seem to have as strong a correlation in more natural therapies such as IUI and natural fertility therapy, but it still tells us a lot about background ovarian reserve. Ultimately, we want this value to be high, because when it's high, it tells us that there are lots of healthy, active antral follicles within the ovary that are secreting this hormone. The advantages of AMH testing, it can be drawn at any time. The levels are stable for several months, such that we can draw it once or twice per year and have some monitoring of ovarian function. The changes that it detects will monitor changes in ovarian function 2 years before traditional testing, such as FSH levels, would detect an alteration. And most importantly, having an AMH drawn prior to fertility therapy has the potential to avoid costly fertility treatment failures.
And John, I've got a question here.
Sure.
This is from Alicia, and she's wondering that, she says, if you have PCOS and have a high AMH, does this mean you will run out of eggs more quickly than those with a normal AMH level?
No, patients with polycystic ovarian syndrome tend to have very high AMH levels. This tells us, a little bit about the background process that causes polycystic ovarian syndrome. PCO patients have lots of eggs. Their eggs secrete AMH, so the PCO patient tends to have very high ovarian reserve. Their issue is in ovulating those eggs on a consistent basis. But AMH tells us a lot about whether or not patients truly have PCOS. We also use it as a marker for response to therapies like metformin, because we see when a PCO patient is on metformin therapy, their AMH levels will drop over time. And then that's not necessarily a bad thing, because it tells us that the metformin is binding more of their active hormone in the bloodstream.
Awesome.
Yeah, that's a pretty complicated concept. I don't.
It is tough to wrap your mind around.
Yeah, that one's sort of beyond the scope of this webinar, but definitely shoot me an email about that, because I can get into that in a little bit more detail. I just don't want to distract the rest of the audience.
For sure. For sure. And we have a few more questions here. This is a great question. We have a question from Tanya. And she's saying, once you have your AMH level tested, how rapid is the decline? And she writes, for example, someone who is in the medium risk, how long does it take for them to end up in the low or very low category?
So, Tanya, the truthful answer is we don't know. I'll tell you what my current practice is. I find that patients who are younger and have normal or decreased ovarian reserve, their values tend to be stable for 6 months to a year, such that if a 32-year-old patient came in and had a normal AMH level, I would be very comfortable not repeating that test for a year. When a patient is older, say beyond age 37, I find that the AMH level declines more rapidly. And if you think about the biology of ovarian aging, that makes sense. So younger women will often still have a smaller pool of ovarian eggs, but they seem to deplete them less rapidly than older women. Does that make sense?
I think that makes sense to me. Yep. And we're getting some, yeah, and Tanya says yes. Thanks, Tanya. We have a question here from Rachel. She's saying, how early is too early to test AMH prior to IVF?
That's a loaded question. Okay, my philosophy is, and this is not shared by all of my colleagues, I don't do IVF unless someone has an AMH level, because I don't like surprises. There is a strong correlation between your AMH level and outcomes in IVF. An AMH test is going to cost you about $65. The average price of in vitro fertilization in a non-funded program is about $10,000. Personally, I'm going to spend the 65 bucks before I spend the 10 grand. And I advise most people to do that. If the AMH is very low, I will often advise people not to do IVF because I find that more natural fertility methods are more appropriate. That doesn't work for everybody because some people don't have an option other than in vitro fertilization. Sometimes either the sperm quality or the quality of the fallopian tube necessitates that technology. But if sperm and fallopian tubes are normal and the AMH is very low, my current philosophy is to push a natural fertility approach.
Just do Rachel's quickly here. Rachel's planning on IVF in April, but would like to do AMH now. Is that something she should be doing?
Absolutely.
Mm-hmm.
So, the theoretical question that I will put out is, what is the downside to doing an AMH test? If it is normal, all it's going to tell you is that you have an excellent outcome opportunity in vitro fertilization. If the AMH is high, you can detect potential risks such as ovarian hyperstimulation syndrome. And if the AMH identifies you as a low responder or a poor responder, then generally you need a special protocol in IVF in order to enhance success. So if you have the option of having an utter failure in your first cycle and using that information to plan your next cycle, or using the information obtained from a blood test, I think most pragmatic people would do the blood test time and time again.
Mm-hmm.
Is there anyone on the call who disagrees? Because it's not as cut and dry as it appears.
For sure. And a lot of this is new technologies too. So
Oh yeah.
Now we actually have this topic always generates a lot of questions because it is so new and it's such an interesting concept that we're able to get this type of testing in. So we have two questions in from Barbara. She's wondering, can you request an AMH test from your physician if you're not going through fertility treatments? And I think the question that spun off for me there was, let's say you're planning a family in 3 years, it's not necessarily something that works right now for your career. Maybe it's 3 years down the road. When's the best time to get an AMH test? And then once you get an AMH test, how long does it take typically to get those results back?
That's an excellent question. I'm going to spend some time on this. I'll tell you a little story. I had a lady come in through our self-referral process last week at 32 years old, and she wasn't trying to become pregnant. She went to her family doctor and said, this is a priority for me. I'm not actively trying to become pregnant right now, but I'd like to see what my options are. And her family doctor told her, you know what, sweetie, you've got nothing to worry about. Women are having pregnancies in their 40s all the time now. So don't give it a second thought. And the family doctor basically ignored the request for fertility testing. Now, that patient came to me through our self-referral program, and I sat down with her for about half an hour, and we just talked. Not everybody who comes to Fertility Ontario immediately gets whisked into fertility therapy. We have the test available. We have counseling available. And sometimes people just want to come in and know what their options are. So for this 32-year-old lady, we did a full profile, including an AMH level. She'll get the results back in about 2 to 3 weeks, and I'm going to sit down with her personally and discuss the results. And if the results are normal, my counseling to her is this result is going to be stable for about a year or so, such that she's going to have some control over her fertility potential for the next year. And if the result comes back abnormal, that person leaves that encounter armed with the information to make her own decisions. It's not pressure. It's not, immediate need for therapy. It's giving somebody the tools they need to create their own success.
For sure. And, Alicia just has kind of a comment here. So it's kind of like the test would be an option. Let's say after struggling, for baby number one, deciding whether or not you can afford to wait before trying for baby number two. It really kind of gives you that information where you get a little bit more information to make an informed decision, basically, right?
Yeah. It's, that's what this whole process is about, information and good choices. And that's why I love the AMH, because I find it very empowering for people. It answers a lot of questions. And, rather than constantly sort of hearing the ticking of that biologic clock, you have a hard number that you can deal with. You have reference ranges that make sense to people. And most people find sitting down and going over their AMH level to be either empowering or a relief, because it has meaning to them. It translates to people.
Mm-hmm. And it could even be a situation where, possibly the test comes back and you have an AMH level that's lower than you, because you made the point at the beginning of the webinar that people often overestimate their fertility potential. So, you might get information back that says that you have fertility levels possibly lower than you thought, and you get to now make a decision with how you're going to use that information to possibly move faster on having a family than you thought you would.
Yeah, the kind of classic example that I often mention to people is a relatively young patient of mine who was 33, and she came in to have AMH testing done, and much to my surprise, her AMH level came back undetectable. And when we ran additional testing on her, she was found to be in premature ovarian failure. Mm-hmm. And unfortunately, the only therapy available for her was to have a donor egg provided to her by another woman. And she went through that process, and it was very costly for her. She had to travel south of the border in order to get it done. And when I met with her to discuss the results, I was very apologetic. And I told her how sorry I was that this was happening to her. And she was actually thankful, because she knew what was going on, and she knew why she wasn't becoming pregnant. And her comment to me was, I could have wasted thousands of dollars on fertility treatment. And because of this test, I now know what I need to do. And that lady is now well into her second trimester, expecting a baby next year. And I can tell you, she could not be more happy.
That's fantastic. That's really great. And I've received just a few comments on here that we've answered a lot of questions for people, that people are kind of in that boat, wondering, basically what their family's going to look like in the future. A few more questions here. We've got a great question. You know what, we'll do Tanya's here. Does AMH lower with pregnancy? That's a great question.
I don't know. I do have a few patients who, around the time where they had sort of unexpectedly low AMH levels, they become pregnant within 2 weeks from that. And so there's a lot about AMH testing that is still unknown. We don't know a lot about AMH expression in pregnancy. We don't know whether or not low AMH levels predict abnormal outcomes in pregnancy, such as chromosomal abnormalities. If you follow, you know that chromosomal abnormalities are more common as you get chronologically older. We don't have a strong correlation now between decreased ovarian reserve and an increase in chromosomal abnormalities. As more women get AMH testing, we might be able to eventually answer that question. But this is something that is still, very much in the forefront or on the frontier of cutting-edge research. It's, we're going to find more about it in the next 5 years than we have in, the past 20, because it's really going to be a game changer in terms of fertility therapy.
Awesome. Awesome. We have Panina, I hope I'm saying your name right. But 2 questions here, and I want to make sure that we get these answered for you. First question is, can someone with a low AMH benefit from IVF? And then she kind of wrote me a second note here saying that she think it was answered. And she wrote, if fallopian tubes are blocked, she can still go for IVF.
Well, that brings us back to, my previous comment where if people have a low AMH level, I don't recommend in vitro fertilization. With the caveat being, some people require IVF. And if your fallopian tubes are blocked, you don't really have many other options. In Ontario, if you have bilateral fallopian tube blockage, the government will fund in vitro fertilization. The medications required for IVF are still very expensive. And, depending on what your AMH level is, the pregnancy rates can often be quite low. Given the cost and invasiveness of IVF, it becomes a personal choice as to whether or not you feel going through IVF is worth it to you. We try to counsel people as best possible. And in select cases, yeah, I have refused to do IVF on patients just on the basis of ethical grounds. But there's no absolute number whereby somebody who makes some level of AMH cannot become pregnant through IVF. I'm just going to wrap up with suggestions for people who are planning pregnancies at an older age. Obviously, we have very advanced fertility therapies available, but these are a few tips that you can start tomorrow. Things that are incorporated into your lifestyle. Things that you can make a plan for the upcoming year with. And you don't need to see a doctor in order to start. Step number 1, get your whole body healthy. And that's not how you look in the mirror. That's how your body feels from head to toe. So you need to decrease or stop smoking. The ovaries in particular really hate cigarette smoke. You need to moderate your caffeine and your alcohol use. And people need to realize that I didn't say stop drinking coffee or stop having that glass of red wine. Just realize that everything in moderation is reasonable. If you're drinking excessive amounts of caffeine in a day, that's not favorable fertility. With regards to alcohol, a glass of red wine a day is absolutely fine. But if you find yourself indulging more often than that, you might be impairing your fertility. Eat good food. a loaded comment. This is something that we're going to be talking about in one of our New Year webinars. The contribution of nutrition and metabolism to overall health and subsequently fertility. But if you're making food choices throughout the holidays or throughout the year, try and choose something that was organic, grown on a farm, not genetically modified. Your body will thank you. And lastly, maintain a healthy body weight. That implies not being too overweight and similarly not being too underweight. People are very hard on themselves with respect to their body weight, but at the same time you need to be realistic. A body mass index is a relatively objective way of assessing how big you are, and we do have reference ranges available for what is a normal body weight. I think we've talked about step 2 quite a bit. AMH testing is a revelation, and it's something that is available at most major fertility centers throughout Ontario. Life Labs in Ontario is now offering the test as well. Unfortunately, it is not covered by OHIP, but depending on where you go, it can be attained relatively inexpensively, and it will give you the best available information to guide your own choices. My experience has been that a lot of people don't want to get this test done because they are afraid of what it will tell them. Don't be afraid. Remember that my lady with the AMH of 0.0 is pregnant now. Getting her AMH tested led her to that pregnancy. Knowledge is power. This is a concept in step 3 that we devoted an entire webinar to. Natural fertility supplements is available on our YouTube channel, and we spent an hour and 20 minutes a couple of months ago on it. But get on a vitamin. Coenzyme Q10 is the new prenatal vitamin, particularly for older women, and Vital Q, which is known as ubiquinol, is the best available form of coenzyme Q10 available in Canada. Through our clinic, we sell several vitamin products by Yadtech that fall under the label of Fertile Pro and Vital Q. For both men and women, coenzyme Q10 greatly increases opportunity at pregnancy regardless of your age. And the final step for success, please get some help. An opinion from a fertility specialist, and I think we had an example of this earlier, doesn't commit you to treatment. Come and talk to somebody like me, or spend an hour with me online, and I'll gladly answer your questions. We really, at the end of the day, are here to help you create your own success. And for some people, sometimes just a clean bill of health is all that you need. There's no harm in coming in, getting the answers, getting the information, and arming yourself with it. And the sooner you can get some quality help, the sooner you can start building your family. So I'm going to wrap up there. We're running a little over time. You know, if you folks have the time, I have the time. I'm going to devote the remainder of my evening to answering your questions.
Wonderful. And we do have a question in here from Nazim. I hope I'm saying that correctly. She just actually brought up a question for the coenzyme Q10. She's wondering, what dose of coenzyme Q10 do you recommend to patients?
Oh, that's, that is, again, a loaded question. My preferred form of coenzyme Q10 is the one you see on the far left, ubiquinol, which goes under the trade name Vital Q. And as we explain in the webinar on natural fertility supplements, this is the most active form of coenzyme Q10 available. So what I recommend for people is 50 milligrams of Vital Q twice a day. If you were going to translate that into coenzyme Q10, that'd be roughly 600 milligrams of CoQ10 a day. The important concept is that that level of antioxidant therapy is not something you can get at the drugstore. You really need to be going to a pharmacy or a knowledgeable fertility center in order to access a good quality supplement like Vital Q. It's a little bit more expensive than what you find in a Shoppers Drug Mart, but it is well worth it. What we get into on the Natural Fertility Supplements webinar is there's a natural decrease in our ability to defend ourselves against oxidative stress as we age. Vital Q replenishes our body's ability to deal with oxidation. And that's very important when people are trying to become pregnant at an older age.
Wonderful. And we have another question here from Rachel. She wonders what your opinion is on royal jelly.
You know, I don't know a lot about royal jelly. It comes up very often, and it came up in our last webinar as well. My issue with unregulated supplements like royal jelly is I just don't know how much activity they have in them. They can come from a variety of different sources. You can often get them at specialty health food stores, sometimes even at some specialty food stores. And because they are distributed by so many different companies, often from the Pacific Rim, it's very hard to vouch for their content. And there isn't a lot of scientific evidence that suggests their benefit. Now, that's me wearing my hat as an allopathic North American doctor. If you really want an informed opinion about the potential benefits of royal jelly, go and talk to somebody who deals in traditional Chinese medicine or naturopathic medicine, because they would be able to give you a much more eloquent and informed answer than I could. For my purposes, I use vitamins and antioxidants because of their proven value.
Great answer. Great answer. So far, there's no other questions that are, oh, we have a few more questions. There we go. So this is a great question. This is again from Panina. She's wondering what your advice is on tubal ligation. If one wishes to have a reversal, what are the chances of blocking them?
A tubal ligation is relatively successful in terms of reestablishing the patency or flow of the fallopian tubes. Whether or not that is going to allow somebody to become pregnant is a guarded question, because hooking the fallopian tubes back together, although it is a very delicate microsurgery and something that I've performed, is still a plumbing issue. It's about getting something to flow from one area to the next. Becoming pregnant and having a healthy pregnancy is so much more complicated than that. And it's just not something that is, can be addressed with a single surgical procedure. So for people who are older, my usual advice is to evaluate your AMH level before deciding on costly fallopian tube surgery.
Panina here, she's saying, where do you go for AMH?
Again, AMH testing is available at Fertility Ontario. It's available in Mississauga at ISIS Regional Fertility Center. In downtown Toronto, it's available at TCART and Create IVF. And in limited circumstances, it can be drawn at a community laboratory through Life Labs, but generally you need to call ahead and arrange it.
John, you just mentioned some areas inside of, kind of closer to London, Ontario here, but Barbara's wondering, where would you get AMH, testing in terms of other areas of Canada, and she brought up Alberta.
In Alberta, I'm not particularly certain where it's drawn. I know Foothills Medical has an IVF center there. Life Labs has also drawn levels for us from patients from Edmonton, and we have been able to arrange that remotely sometimes. Calling a local Life Labs and asking about specialty testing might be an option, or talking to one of the major fertility hubs in Alberta. Either, I think it's the Alberta Fertility Center, which is Dr. Cal Green, or the Foothills Reproductive Center.
So Rachel has a question here. If you have AMH testing, should you continue with 3-day FSH testing? And I'm just hoping that I just don't know what that is.
The day 3 FSH is the more traditional testing of ovarian reserve. In our IVF program, we have cutoffs for whether or not a patient can proceed based on their day 3 FSH level. So it is still the standard. It is inferior to AMH levels, quite honestly. But because AMH is still a relatively new test, the conservative thing is to get the traditional testing done as well.
If there is anything that we haven't answered, or if it's an hour from now you're going, oh, wish I would have asked that question, you can email John directly, and I believe his email is associated with the invitation to this webinar. So you can email him directly to get your questions answered. And also, one thing that you can do to kind of keep in touch with us and know when these webinars come out, because we do try and hold one once a month. And right after this, we like to take these and make them into videos and put them up online, both on the Fertility Ontario YouTube channel and up on Facebook. So if you go to facebook.com, and I can actually type in the link here for everybody, I can send the link, and if you want to like us on Facebook, when we have new information coming out, new webinars, you can be the first people to know about them and join us again. And also, if this webinar was really great, and let's say that you have somebody who you wish was kind of joining us today but they couldn't make it, you can share the video link and they can watch this for joining us.
Thank you very much, everybody. I really appreciate you coming out. I know how close to the holidays it is. And I appreciate you suffering through my gravelly cold voice. Please don't hesitate to email me. It's a part of my job that I really enjoy, is interacting with people. So if you have a question, that's what my email address is there for. And happy holidays to everybody. And at the risk of being politically incorrect, Merry Christmas.